Okay, welcome to the leg pain. This is gonna be a tough one, so you gotta be ready for this. You ready? Okay, let's go.
Sure,
Let's go.
sure.
So, when you have a patient present to you with swelling of the leg, and there is you have erythema, redness, all these good stuff, what do you think of? You think of these differentials. Could be cellulitis if it's warm, if there's a fever.
Sure,
It could be a
sure.
trauma based on the history. Tell you, oh, I had a trauma. It could be deep vein thrombosis. That's gonna be our topic for today. It could be thrombosis, just like hereditary or whatever. It could be Baker cyst if associated with rheumatoid arthritis, usually. It could be lymphedema. Okay, usually with the trauma, they obstruct lymphatics or cancer. Okay, so this is our differentials we have in the back of our mind. So the presentation usually, like this case that we're gonna talk about, it's more like a deep vein thrombosis based on the risk factors. You look at the you suspect that it's a deep vein thrombosis after physical exam. You do the Hammond sign. They tell you on the CCS, so it's gonna be easy. In the emergency department, the patient. Okay, what do you do after that? After that, you do the lower extremity Doppler. You do D
Yes.
dimer and CBC CMP for everyone. Okay? After that, you get the results. Once you get the results, boo, there's a clot. There's a clot in the vein. So there is something going on. Now you confirm DVT. What do you do after that?
Okay, so you confirm the DVT, you see, you check the stability of the patient, if the patient is stable or not. So, and then you look for if there is any
Stable,
contraindication
yeah.
for anticoagulant. Yes, you see the stability of the patient
Perfect,
and check,
perfect for
check if there's
anticoagulant. That's what I,
coagulant.
yeah, that's what I wanted to hear. So how do you do that? So there is sequence in CCS. If you mess the sequence, it's not like in real life. If you mess the sequence, your score will be messed up. So there are sequence. For example, you always do PT, PTT. So if you think of or giving anticoagulant, you can't just give it right away. You do PT, PTT, INR,
I know.
FOBT, and then you advance the clock, get the results.
Yes,
If they are fine, then you start the orders of
anti. Yeah, that.
enoxaparin, warfarin. Okay, these the things. These are we do. So there are timing and sequencing. This is very important, and monitoring. That's all about the CCS. Okay, so this is the PT, PTT, INRFOBT, and then the enoxaparin and warfarin, oral, both oral. And if there is pain, you can give Percocet oral, and you counsel the patient. Okay, counseling. After that, he's just in an emergency room. You send him home and follow up in a day. Okay, you bring him back in a day. You what do you do after that? After you bring him back in a day, what do you think?
Uh, so we go with the new technique. There is no more warfarin in real life, honestly. They usually use something called abixipam or arga or the other the new one was called
Dabigatran and like
dabigat. Yeah. So
yeah,
not that. No, 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 not dabigatran. It's called
yeah.
Xarelto. Anyway,
Rivaroxaban. That's it.
Rivaroxaban. So thank you. Yeah, Rivaroxaban factor 10. We usually use this because we don't want to monitor INR at all.
Yeah,
If
that's
you use
that's yeah,
this,
that's a smart way. However, in the
mm,
CCS, I remember when I was studying for this stuff, there wasn't Rivaroxaban, so they want
I
you
know,
to know
I know, I
how the
know.
warfarin. So this is what you do: you bring him back next day, you check for PT, INR, history, physical exam. Okay, and then you bring him back the second day. Okay, you do the same thing: PT, PTT, INR, till the INR between 2 to 3. Okay, and then you bring him
This is
back
the
on,
therapeutic range called
yeah,
therapeutic range.
exactly, that's the therapeutic range. And then you bring him back on day 3. On day 3 you do CBC. Okay, why do you do CBC on day 3?
CBC.
For heparin. Heparin
And
causes
yeah, to check
platelet.
the
Yeah, causes a platelet.
hematocrit mainly and the platelet.
Yeah.
So if there is a drop in hematocrit or drop in hemoglobin, that means okay, there is something wrong
Mhm.
because we are giving a warfarin, and we check for the platelet if there is any platelet defect while we are starting the blood thinner.
Okay. Now I'm gonna twist the case for you. What if the patient have renal failure?
Okay, if we have the renal failure, we will gonna shift from low molecular weight heparin to what's called the other heparin, the fractionated heparin, or what's
Yeah,
called.
good job. It's the
Uh,
unfractionated
yeah.
heparin. Okay.
So
So
by the way, in real life, okay, the the one in the hospital, I don't want you to be confused, but when in the hospital, they do, sorry, they don't say um, they don't say low molecular weight heparin. They say like Lovanax. Okay, this is what's called in the United States.
Lovanax. Okay. Okay.
Lovanax. Okay,
Okay.
and for the other heparin, for the unfractionated
Okay.
heparin, they called heparin.
Heparin. Okay.
Okay,
Okay.
yes, high creatinine level heparin. Otherwise, Lovanax.
Okay.
Easy.
Perfect. Easy. But what do you have to do before unfractionated heparin? You gotta do the PTT. PTT before
Yeah.
the unfractionated heparin. This is
Yes.
important. Okay. So there are timing and monitoring. This is timing. Timing is very important. We'll repeat it one more time. Number
Mhm.
one, Doppler immediately after physical exam. Number one. Number two, PT, PTT, INRFO, BT before anticoagulant. Third
Mhm.
one, you do INR PT every day for 3 days till you reach therapeutic range. And number four, CBC on day three. Boom! Now you mastered the DVT. Now let's see if the case changes. What do we do? Okay, so
Mhm.
if an outpatient management is slightly different from an inpatient management. So for
Mhm.
outpatient management, what do? You give Lovenox plus Warfarin, okay? And then
Mhm.
you check platelet on day 3 and day 5, okay? You can do that. And then when do you discontinue the low molecular weight heparin, the Lovenox?
Mhm.
When? Huh?
When you discontinue it,
Yeah, you just
it's yeah,
we because
sometimes like for 6 months.
so so it's a bridge, the Lovenox is just because a bridge. Warfarin takes time to take
Ah,
effect,
yeah, yeah,
so
till
that's
the
why we give.
72,
Yeah. So
72
after,
hours.
so not the hour, it's the INR. If the INR 2 to 3, then we stop the Lovenox, the low molecular weight heparin.
Okay.
Okay. And when do we stop? Another time is that if the platelet drop below 100,000, or if it decreased by 50%. Okay.
Mhm.
So this is the outpatient. Lovenox warfarin, check platelet, day 3, day 4. Discontinue low molecular weight heparin ANR 2 to 3 and stop if platelet less than 100,000 or decrease by 50%. Okay, now the management. What if it's inpatient management? Boom, it's different. So what do we manage? We give unfractionated heparin, we give the
Mhm.
warfarin together, and then we do PTT monitoring. What is the therapeutic goal of PTT if we give unfractionated heparin?
Oh,
It's a hard question. Between 60 to 80,
yeah.
that's the
Okay.
therapeutic goal. And you offer bed rest if it's a severe, if it's massive DVT and inpatient, just bed rest. Okay. Now, I have a question that is very, very important. For how long do you keep him on warfarin?
Uh, yeah, it's a good question. Actually, there is a criteria for that. There is a new criteria. I don't know if it's in CCS, but there is a new criteria. We do it in a calculator in the hospital. But
No, so
let's
I'll
forget
give
about.
you, yeah, I'll give you the easy step about criteria. Today I saw a patient who had a DPT, and
Hmm.
she went on it. She was on it for 3 months. So the reversible causes, if it's just after surgery or oral contraceptive pill, just for 3 months. But if it's because of a cancer, pulmonary embolism, or recurrent inherited deep vein thrombosis, then we treat for life.
Yeah, lifelong. Yeah.
Okay, very serious.
Hmm.
Okay, here we go. We're done with the DVT. Let's do a quick recap, okay? You help me out.
Okay, sure.
Symptoms of DVT. What's next?
Okay, you go for ultrasound,
Perfect.
Doppler.
Now you confirm DVT. What next?
Okay, you check for BT, BTT, INR.
Excellent. And then you give medications. What next?
Yes. Okay, you give me the medication and you, you check the INR till you get the therapeutic level of INR.
Perfect. Quick recap. Symptoms of DVT,
Hmm.
ultrasound. You want to think of
Yes.
anticoagulant, PT, PTT, INR, FOBT, and then anticoagulant. After you start the anticoagulant, there is post anticoagulant monitoring. So anticoagulant, there is a pre and post anticoagulant. Pre is PT, INR, FOBT. Post is that we do physical exam, PT, INR every single day for 3 days, and
Mm-hmm.
CBC on day 3. And here is the DVT. It's simple and easy. Thank you so
Yeah.
much for listening, and we'll see you on the next class.